Welcome to the Born of Science podcast. I'm your host, Kylie. Hi everyone, welcome back to Born of Science. I'm your host, Kylie, and today we're going to talk about what fertility treatment even is. It seems like a lot of people are doing IVF these days, and this journey of infertility that used to be whispered about, that was very shrouded in shame, is now blasted online for the world to see. You can go on any platform and see all sorts of people going through different kinds of shots and talking about their journey of infertility. And this is not a niche issue, and quite frankly, it never has been. It's one of the most common medical journeys of our generation, and for millions of people, unfortunately, getting pregnant isn't this wonderful private experience. It's very clinical, it's very expensive, scheduled, and emotionally torturous. So why are people choosing to go through this? It's a pretty complex answer, but to understand that why, I want to help us understand, how do people get here? In this episode, we're going to discuss a few things. What is generally supposed to happen during the process of conception, how many people are actually having problems conceiving, and then the various types of infertility and how they might diagnose you. We will also walk through some of the treatment options at fertility clinics or alternative methods, and why this journey ends up being a very difficult hurry up and wait kind of process. And I will also try to quote my sources to you as I bring them up, but especially sources you can go to try to learn more about whatever your case for infertility may be, or just learn more about treatment in general from verified sources. Because once you step into this world, you realize very quickly that there are many, many actors who try to take advantage of you and your circumstances, from people selling weird supplements online, which are generally unregulated, by the way, to people claiming that they can cure you. So I want to break that down. I want to help you be prepared so that when you encounter this information, it's not overwhelming. But especially, I can't imagine starting my journey today in 2026. I started probably 2019, 2020 is about when we found out. And it was a lot less overwhelming. TikTok didn't even really exist in America yet. It was there, but barely. And now when you go on your algorithm, if they even get a hint that you are interested in pursuing more information about this stuff, you're bombarded. So we're going to talk about this. I'm going to give you some great resources that are actually evidence-based, and we'll go from there. So let's get started. Okay, so section 1, we're going to talk about what is generally happening in the process of conception. When trying to get pregnant, a few things need to happen. A woman releases a mature egg from the ovary, healthy sperm fertilizes that egg, and then the fertilized egg, and we're going to call it an embryo here for the sake of brevity, but there are many, many stages of development. It makes its way through the fallopian tube and into the uterus. And then the cells of that embryo are continuing to divide normally. And then the embryo must implant and continue to grow normally for the next 9 months. If there are any issues at any point along this process, issues with sperm, issues with egg, issues with an embryo, issues with uterine lining or maybe uterine blockages, issues with the release of healthy egg or sperm, maybe there's very low or no sperm, maybe there's very low or no eggs, there could be chronic inflammation, there could be hormonal imbalances. I agree that we are being poisoned left, right, center. It's everywhere, and that is affecting our fertility. But interestingly, at least as far as the data shows now, and I will say with the caveat here, it is hard to quantify data that didn't exist, 2,000 years ago when it comes to infertility. But specialists generally agree that it's been about a rate of 10 to 20% infertility worldwide throughout human history. And human reproduction, contrary to what we've been taught, is generally pretty inefficient. And if you don't get pregnant that first month, it does not mean you're infertile, and it does not mean that you have to go straight to IVF. So let's just briefly talk about the diagnostic criteria for infertility. And I think most people know this, but we will just briefly review it. Infertility is defined as a failure to achieve pregnancy after 12 months of regular, unprotected sexual intercourse around the time of ovulation. Well, technically before ovulation. And for women under 35, that's typically the range. For women over 35, you've got about 6 months. And then women over 40, they recommend just seeking an evaluation sooner versus later from a fertility expert. And for men, it's about over the age of 40. Some people say 50. There's a lot of arguments there. I'm getting this data from the American Society of Reproductive Medicine, but they do say that about the age of 40-ish, the sperm quality starts to decline by a certain percentage every year. That does affect the health of the embryo. So approximately 85%-ish of infertile couples do have an identifiable cause of their infertility. So some of the most common causes are the male factor infertility, which there are many of those, but low count, low motility, we know sperm counts are dropping. There is ovulatory dysfunction for women and tubal disease. And that also came from the American Society of Reproductive Medicine. A few more statistics here. The cases for infertility are about split down the middle, 50-50, due to men, due to women. And when you dive into it a little bit more, again, American Society of Reproductive Medicine, you can go find all this here. About a third of all cases are due to women specifically. 1/3 of all infertility cases are due to men. And then the other third is due to dual factor infertility, whether it's men and women in the heterosexual couples, or maybe you've got a single person trying to conceive, can't really do that by yourself. And then you've got heterosexual couples, also that should be pretty self-explanatory. So when we talk about people having problems conceiving, let's kind of jump into section 2 here. Today, globally, about 1 in 6 couples are experiencing infertility. It's like roughly 17-18%. And I mean, these are really rough estimates here, 48 to 186 million people. I mean, not everybody goes to seek care. It's, again, a little more difficult to quantify. In the United States, about 10% of women ages 15 to 44, so those are kind of your childbearing years, report difficulty getting pregnant and or carrying a pregnancy to term. And so we're including early miscarriage, recurrent miscarriage, loss. And in high-income countries, about 17% infertility. Low-income countries, about 16% infertility. So really, the rates are remarkably similar worldwide. And that's World Health Organization data, so you can go look that up for yourself as well. I thought this was interesting, and I wanted to add some data and context for infertility throughout different eras. Pre-industrial revolution, the infertility rate, again, varies. 10 to 20% is the estimation, and there's just some biological infertility. Many of these cases were probably hidden by high birth rates, earlier birth rates, early marriage. There were some pretty high infection rates from things like STDs, which can lead to certain levels of infertility, things like tuberculosis, that caused infertility, and there was little medical diagnosis at the time. 50s, about 8 to 12% of couples was the estimated infertility prevalence. Early childbearing, again, masked a lot of the age-related infertility. This was pre-women's lib, so there's a lot of factors to take into consideration there. And then today, 2026, it's about 15 to 18% of folks. That's the prevalence of infertility in our communities. This is due a lot more to things like delayed childbearing. When we think about our moms, our grandmas, our great-grandmas, what age were they having babies? Probably not starting at 30. 19, 20, 21, 22. We also have a lot of environmental exposures, and we have way better diagnosis to help people understand what is causing their infertility and then how to overcome it, or if they can, reverse their symptoms. There's some evidence here from some modern epidemiology sources that suggests infertility hasn't really dramatically changed biologically. It's always probably affected about 1 in 6 to 1 in 7 couples. So what are some of the things that are contributing to better birth rates? We have better diagnosis and reporting. We've got a lot more reduced infections and maternal mortality, but there are more lifestyle and environmental factors, unfortunately. So we do have a lot more awareness about these issues and a lot more treatment options available, such as IVF. Bottom line here, roughly 15 to 18% of humans are struggling with infertility at some point, both globally and historically, and the rate hasn't clearly increased due to, the fact that we're being poisoned or the fact that this or the fact that that. It's just that the visibility has exploded and treatment for these cases have exploded. And anyone who goes through this full well knows that they don't want other people to go through this. And so if there's a way to try and make it better for other people, they're going to talk about it, myself included. So section 3, what are the various types of infertility? Like, what does this mean, and how might you go about being diagnosed? So I want to lay out a few of the reasons why people might not be able to have kids. There's male infertility, female infertility, dual couple infertility. We talked about that earlier with the thirds, same-sex couples, and single individuals. So let's touch on some male infertility causes. This is not fully comprehensive here, but I am of the opinion that this is super, super important to get a diagnosis for both people who are experiencing infertility ASAP, because traditionally this has lied upon the shoulders of the woman, and women have been put through crazy amounts of treatments, surgeries, and invasive biopsies, painful procedures, when all along it was their partner who had the infertility. And again, it is not invasive to go and just give a sperm sample and see where things are at. And if you need to dive deeper, you can dive deeper. So again, few medical causes. And if I'm saying these incorrect, I'm sorry. Varicocele, that is the swelling of the veins that drain the testicle and or penis. Infection, again, we kind of mentioned STDs earlier, maybe inflammation of the epididymis or testicles. Retrograde ejaculation, to bodies that may attack sperm, tumors, things like cancer, hormonal imbalances. And these can be things related from the hypothalamus to the pituitary, thyroid, adrenals, any defects of tubules, chromosomal defects. Those are a little less common. Medications, if you're taking testosterone, long-term anabolic steroid use, cancer meds, ulcer drugs, arthritis drugs, prior surgeries, obviously vasectomies, any testicular surgeries, prostate surgeries. I'm not saying that these things are causing infertility. I'm saying that they can have an impact depending on what you had to go in and get treatment for. Any unexplained infertility, low sperm count, low motility, high DNA fragmentation, meaning damage to the cells, some simple things. If you're sauning too much, if you're cycling too much, if you're in the hot tub too much, maybe the chemicals are imbalanced, things like that, where the sperm is exposed to high levels of heat, it can really damage them. That's why they're outside the body instead of inside the body. Environmental causes, any industrial chemicals, pesticides, herbicides, organic solvents, painting materials, heavy metal exposures, radiation, x-rays, we kind of already know that too. Some lifestyle causes, drug and alcohol use, and that does include cannabis, tobacco smoking, any obesity. Men are constantly producing sperm about every 3 months. Some of these sources are from the Mayo Clinic, by the way. Let's jump into female infertility. Now, these medical reasons can be a little more complex. Things like ovulation disorders. PCOS is the #1 cause of infertility for women. Too much prolactin, hypothalamic dysfunction, amenorrhea, primary ovarian insufficiency, diminished ovarian reserve, and then there's damage to your fallopian tubes, pelvic inflammatory disease, maybe STI, STD damage, previous surgeries. Again, not saying surgery causes it, just saying, was there scarring? What were you going into surgery for? Were you kind of in and around your reproductive organs? Some things to think about. Ectopic pregnancies. Sometimes you can lose a tube. Endometriosis, another huge factor for female infertility. The tissue that should be growing in the uterus is growing outside of the uterus, and they kind of have these broken up into stages, stage 1, stage 2, stage 3, and it does behave like a cancer. It can spread throughout your whole body. It's horrendous. Right now in 2026, the only way to diagnose that is through surgery, uterine or cervical causes. So polyps, fibroids, tumors, maybe your uterus is unusually shaped, maybe cervical stenosis, narrowing of the cervix, any cervical mucus issues, adenomyosis, recurrent miscarriage, and that's some of the more common, not fully comprehensive, but more common reasons of female infertility. Then dual couple, so maybe, there's a combination of both of these types of infertility. So who are the folks that can help you address these problems? Where did I start? I started at my OBGYN's office, and I actually saw a certified nurse midwife, and she helped diagnose my PCOS. I went in on one cycle. She asked me a few questions, and then we did a pelvic ultrasound. She saw the cysts on my ovaries, and at that point, we did a blood test. And it was throughout the next cycle where we did one on day 3 as a baseline, and then day 21 to try and confirm ovulation with progesterone levels. And that confirmed that at least that month, I hadn't ovulated. And so that's how I got my diagnosis. I knew that there were some familial genetic factors that kind of gave me hints and clues as to what was going on. And so I kind of came in saying, hey, I think I might have PCOS. Can we look into this? And that's how I did it. Who else can help you there? The nurse practitioners are always awesome. There are alternative practitioners. I personally would never try to get diagnosed by one, but they have really unique expertise depending on who you go see to help treat whatever your case may be. Are they the official, board certified experts in infertility? No. And when you go in to see someone like that, I think you need to be aware of that. Try to know, you should honestly ask every practitioner you ever see or look them up before you go in. What are your credentials? Where did you go to school? Who are these alternative practitioners? Integrative practitioners, sometimes these are folks who were in the medical field before, nurses, nurse practitioners who maybe decide they want to go a different route and try to treat some folks more holistically. There are registered dietitians, which they are very credentialed. These are folks who've gone to get their masters of nutrition. And then sometimes they can specialize even further. There are many registered dietitians specifically for PCOS, and I follow quite a few of those that have given me wonderful information. There are naturopathic fertility doctors, and I dive deeper into this in my episode, probably right after this one is when I'll post that one, just more about my journey and how I feel about those types of practitioners, but they do exist. And at least the one that I did go and see, she got her undergrad and then went to a naturopathic doctor kind of medical school. So they call them doctors, but they are naturopathic doctors. They didn't do the traditional med school route. Arguably, they were doing more traditional medicine to begin with, but we don't have to go there right now. There are NAPRO doctors. So these are restorative reproductive medicine doctors. Sometimes they're OBGYNs who then go to kind of an alternative school to look at other ways to solve these cases of infertility. I have asked many a reproductive endocrinologist, I should say, who is the fertility doctor, how they feel about this treatment. And I'll say this more broadly. When you speak with anyone in the medical community from different realms, even some of the most credentialed folks will butt heads all the time on, no, this is correct, no, that's correct. And in this particular case, NAPRO doctors, you should go do your own research and figure out for yourself what you think. And then as far as other practitioners who are not necessarily credentialed in helping people treat infertility, anyone with a Chinese medicine background, acupuncture, fertility coaches, I'm not saying that these people can't help you. I'm not saying that they have not had success in the past. I am saying that they are not the experts in reproductive medicine. So who are those? A reproductive endocrinologist is a fertility doctor. Sometimes they call them reproductive endocrinologist and infertility expert. Typically, they're OBGYNs who they go to medical school, they go to residency, and then they do an additional fellowship in reproductive endocrinology, meaning like all things infertility with the human body. 3 to 4 years, I've seen different doctors going through those fellowships. Sometimes there's also reproductive andrologists. Less common, but they do exist. This is someone who's a urologist. So instead of, the OBGYN for women, the urologist for men, they then go on to specialize in male infertility in particular. And as far as I know, I've never seen reproductive andrologists at fertility clinics, unless they're the men's clinic is typically where you might see that. Again, I'm not saying that this is every case in every part of the country. This is a broad generalization here. Reproductive immunologists, these are much more rare, but these folks are pretty specialized and they study the interactions or the absence of these interactions between the immune system and components related to reproductive systems. So for example, like maybe maternal immune intolerance towards the fetus or other immunological interactions. All right, so we got all those: OBGYN, urologist, alternative practitioners, reproductive andrologists, reproductive endocrinologists, your fertility doctor, and then reproductive immunologists. Okay, section 4, fertility treatment options. So we've come this far. We're trying to get pregnant. It's not working out. We might have gone to find a diagnosis or at least visited a fertility clinic to seek further diagnosis and treatment. What are they going to do? What happens specifically at a fertility clinic? So I will outline the first 3 options that happen at fertility clinics, and then 4th option. Okay, fertility clinic. There's medicine that they can give you. There are surgical and non-surgical procedures that they can do for you. And there is assisted conception, sometimes also called assisted reproductive technology, shortened to be ART. When we talk about other, governing bodies, SART is the Society for Assisted Reproductive Technologies, and then ASRM is the American Society of Reproductive Medicine. Okay. And then there's holistic and alternative methods. I'll get to that in just a second. But anyway, they don't typically do those at fertility clinics. So medicines, Clomid, Letrozole, these are some pills that can help induce ovulation. And they also use these pills for men. Sometimes you might also have something called a trigger shot. This is a medication that, again, can help when you're trying to ovulate. There's also much more specialized medication to treat for things like diminished ovarian reserve, things like a primary ovarian insufficiency. Sometimes if you have endometriosis or other conditions where it's extreme inflammation, maybe you might be put on Lupron and try to suppress that inflammation for a few months. So those are a few different medications that are very common that you might be introduced to. Generally recommended supplement and lifestyle adoptions. Will you get these from your clinic? Probably not. Probably not. I've met with 4 reproductive endocrinologists in my journey. This is not because I'm necessarily bouncing around. The way that this happened for me is we initially started out at one clinic. That doctor treated me. We weren't happy with the way things were going and ended up switching clinics, which is actually a pretty common patient experience, unfortunately. I met with another doctor. They treated me and I got my first child. And a few years later, here I am back at it again. And I went to go meet with another doctor. And unfortunately, that doctor was leaving as well after having, given me some consultations and a baseline. So I was pushed to another doctor. And even then, if you want to say 5, I've been treated by 5, but that doctor managed my care and managed my protocol, my calendars, all of the blood work, the things that I was doing. And then the day of transfer, frozen embryo transfer is what I did. A different doctor actually performed the transfer procedure, who I peppered with all of the questions I possibly could in the time that we had. And I guess she also happened to do my egg retrieval, but I was out for that procedure, so I didn't know that, didn't remember that. So anyway, that doesn't matter. But the point is here, I have seen many, many doctors, and none of them have ever told me to do XYZ for diet and lifestyle changes or recommendations. These that I am about to tell you right now come directly from ACOG. That is the American College of Obstetricians and Gynecologists. Again, from ASRM, I've said that a few times, and from SART. You should be taking a prenatal vitamin several months before trying to conceive. Some people say 3, some people say 6. But your clinic will also probably put you on a prenatal before you go in for treatment, at least a month before. Men should be staying away from heat sources. We already touched on this one. If you're a cyclist, if you hot tub regularly, if you're sauning regularly, it can damage your sperm. And remember, it will take about 3 months to produce new ones. Any alcoholic, recreational drugs, smoking, high caffeine intake, limit all of that exposure or cease it entirely. And then limit your exposure to endocrine disrupting chemicals. These are the hormonal disrupting stuff, all that crap in our air, water, food, and personal care products. Things like plastics, BPAs, phthalates, parabens, and I will dive deeper into breaking all of this stuff down later. I think it is so, so, so important. Imagine with all of the technology and all the advances that we're making as a society, if we also stopped poisoning ourselves, could we actually reduce the infertility in our society amongst our population permanently to make it really as low as we possibly can? Does anyone care about that right now? Doesn't seem like it, but would be nice. Limit your stress. And I know that's like a dumb thing to suggest. I know that this process of, oh wait, we've been trying so much and oh my gosh, all my friends are doing IVF and I don't want to do that. I can't afford that. I don't want to get shot up with hormones. I totally get it. It is a really stressful experience. So whatever that means for you, whether you're taking more baths, whether you're exercising more, whether it means massages or reducing all of your screen time, don't doom scroll. These are really, really important things for your body. Stress has a major impact on our fertility. And if you're a very high weight or a very low weight, that may be brought up as well. Your doctor will go over all of those things with you. Okay, so there are a few caveats here and summaries from the latest suggestions from these governing bodies that are there for couples trying to get pregnant. And I wanted to talk about them because this data is kind of spread out. I just want to bring it into one place here. Currently, there is insufficient evidence that a particular diet will improve natural fertility. And I know some people might hear of like, oh, the fertility diet, the Mediterranean diet. Those exist, and it is super, super important to eat healthy, to cut out all your processed food. Yes, of course, we know we need more protein. We know we need more fiber in our diets. But there is a variety of studies saying that it can help, but there's just as many saying that there's really no change to adopting this kind of lifestyle. That being said, if money is an object for you, don't stress about it. Just try to make healthier choices and be more aware of what you're putting into your body and how that is affecting all of these other systems in your body, especially when it comes to things like inflammation. And I tried to find more info supported by these organizations I mentioned previously, like the ASRM, ACOG, SART, because there are some recommended supplements. I mean, you'll get pushed so many supplements on social media. It's crazy. Things like CoQ10, DHEA, and inositol, for things like PCOS and endometriosis and whatever you might have. These are discussed and may be recommended by your doctor to help with things like egg quality or help your insulin resistance. And at least as far as the studies that I could get access to as a non-credentialed person, the results are good / indeterminate by adding these supplements into your diet and lifestyle. So go ask your healthcare provider. When it came to my results for my egg retrieval, I had prior to that done a very intense naturopathic protocol where we detoxed, and I put all that stuff in quotations because providers will say things like, you have a liver and you have kidneys, you don't need to detox, they do that for you. I hear you. And I have completely anecdotal evidence, which is not even on the pyramid of scientific evidence as far as quality goes, because it's just anecdotal. This is just my experience. And I will get into that in my story again in the second episode. But when I went into egg retrieval, that experience was crazy because I had such a high number of eggs, and we had, even with my husband's poor sperm, low count, low motility, high DNA fragmentation is what he had. We had some pretty good results for the very first time of ever having gone through this experience. Do I factor that naturopathic protocol where we got super healthy? We tried to reduce inflammation. At the time, it was believed that gluten and dairy can help with your PCOS. That has since been debunked, but we went gluten-free, dairy-free, pretty much sugar-free, no processed food, all organic. We were sauning, and then we had a certain slew of supplements based upon environmental and like full panels of blood work beyond a CPC to determine what we might need to help our bodies with as far as nutrition goes. We did all that. Yes, I do contribute our success with IVF by having gone through that protocol. But again, I can't prove it to you. It's not evidence-based. And I do have some levels of proof, but we'll get into that later. Anyway, point is, go ask your doctor if any of these things might be helpful to you and what they recommend, at least as far as what I'm doing right now. I was told to get off of inositol when I go back in for an embryo transfer. So the only things I'm taking right now are a really good prenatal, which that was important to me. I made sure to find a good prenatal that had a lot of evidence behind it and that had at least some certification, because supplements are not even regulated by the FDA. And so mine, I believe, are NSP certified. They're made in Canada, but it's Burden B. I mean, this is not sponsored. I'm just telling you, I really liked their stuff. They've got iron, they've got 2 different types of the folic acid that you need, and all sorts of different nutrients that all different kinds of doctors are able and willing to put their name on. So I felt good about that. Do you have to get something super fancy? My OBGYN said no, but again, I've even seen fertility doctors in the same breath. I could pull the clip up for you right now. They will say, supplements are not regulated. It doesn't matter what you take, just take anything. And it's like, wait, what? They're not regulated, so there could be just about anything in it, and all we need is something with a folic acid and a few other nutritional supplements, but it's not regulated, so I can't prove that, and I don't know if it's quality or if there's other crap in it. I digress. So I'm taking a prenatal, and then I'm also taking a vitamin D, and that's it. That's all I'm taking as far as supplements go, at least for this embryo transfer process I'm in right now. All right, enough rambling about me. surgical procedures. What are some surgical procedures that you might be introduced to at your clinic? Fertility surgeries. There's biopsies, things that diagnose endometriosis, diagnosing pelvic pain, treating ovarian cysts. That's something that I have had done. I had a dermoid cyst. I had two dermoid cysts, but it only looked like one. Had that removed, treating uterine fibroids, extracting sperm, fixing sperm blockages, reversing vasectomies, on and on and on. Fertility surgery. Non-surgical interventions. And when I say non-surgical, I don't mean non-invasive, because some of these are pretty freaking invasive, and I'm pretty disgusted at the fact that there is little to no pain management for some of these procedures. Let's get into those. There's an HSG, hysterosalpingography, pretty sure is how you say that. It's an x-ray procedure, and you're kind of on this table, and they're blowing dye through your tubes. It's mainly meant to check your tubes. It will also look at your uterus. It can sometimes unblock your tubes. And then there's the saline sonogram, way less invasive. I've also heard it called a water ultrasound, but essentially they're putting water into your uterus to take a look at things, make sure everything's looking copacetic. And they're using sound waves. Again, it's just a sonogram, an ultrasound. There are also a few other kinds like hysteroscopy, laparoscopy. So ask your doctor about those. Assisted conception, the next section. So assisted conception is when you can't do it by yourself, you're going to get some help. So does that mean medication? Things like letrozole, clomid? Technically, what we're talking about here is things more like IUI and IVF. IUI is intrauterine insemination, meaning you take a sample of sperm, you clean off the seminal fluid, and then you pick some of the strongest sperm, insert them via catheter into the uterus, and hope that egg and sperm meet around the time of ovulation. So you're bypassing a few potential blockages in that scenario, trying to make it a little easier for egg and sperm to get together. Sometimes you can do this medicated, meaning you take something like a clomid or a letrozole. Sometimes you might even have a trigger shot. And sometimes this might be covered with insurance. It just depends. It was about 2022, 23. We had to do 3 IUIs or prove that we had gone through 3 IUIs before they would be willing to pay for IVF. That's pretty common. And when we went through our IUIs, we did not have fertility insurance. When we went through IVF, we did. And so we had to prove to them and show records that we had gone through those things already. So don't be surprised if that happens to you. What is IVF? This is the big word. This is the one that everyone has big ethical issues with, and it has a lot of controversy surrounding it. And I am excited to dive into it because it is such a fascinating world to learn about, and I think people just don't know. And unfortunately, when you come into this world, you should know. You should know at least at a base level what all of these things mean and how that can affect you. So it's 2 big main parts. Okay, IVF. What is it? It is in vitro fertilization, meaning in vitro, in glass, you are bringing sperm and egg together outside of the body in a petri dish to try and overcome whatever factors of infertility you may have, and then you are putting that embryo back inside the uterus. Part 1 is egg retrieval. Part 2 is embryo transfer. Part 1, egg retrieval. You're probably taking some belly shots, and this will produce a lot of follicles at once, so that when the doctor goes in to retrieve them, you don't have to go through this process many times. It can be pretty taxing on the body. So those eggs are retrieved when they are mature, and then the sperm is prepared. So you're either getting a fresh sample, or you might have a frozen sample of sperm. Your partner might have had cancer when he was younger, or he has a very low count and they had to go through surgery to try and extract sperm. So it could be fresh, could be frozen. And the sperm and egg are brought together in that petri dish in the lab. The person who handles this is an embryologist. Sometimes an alternative fertilization method called ICSI. This is intracytoplasmic sperm injection. This is actually becoming much more common than the traditional IVF, where they are injecting a sperm right into the egg. And this method is really good at overcoming a lot of male factor infertility issues. And for us, we ended up splitting our results right down the middle. So from the eggs I retrieved, from the sperm we got from Paul, we decided to split those results right down the middle between ICSI as a fertilization method and IVF as a fertilization method. And we had really great results with ICSI. Many clinics will cryo-freeze of any available viable embryos at this point, left over after the cell division process. And I want to be very clear here. This is where people say, oh, there's millions and millions of babies on ice. And first of all, you can't know that because that's not a thing that is quantifiably tracked at a national level. You don't know. You're guessing. And you're trying to make something sound more salacious than it is when there are plenty of salacious and interesting and quite frankly questionable parts of IVF that could be discussed. But I digress. The when those eggs and sperm are coming together, there is something, they kind of term it the Hunger Games as a joke. It's this major process of attrition where not every egg that may have been retrieved could be fully mature. And maybe the sperm that was retrieved was not high quality. Maybe the egg was not high quality. And so while you bring them together to fertilize, not everything fertilizes. If it fertilizes, it might not continue to divide properly. And so the cell division in these next 5 days drops off dramatically, meaning as that sperm and egg comes together and that little human embryo starts to grow and develop, sometimes that development just stops. And they don't know why. But that big process of attrition is what can be really emotionally heartbreaking and taxing when you go through IVF, because while there are statistics that can back up what they think is going to happen, there's still just so much unknown about human reproduction that they just can't control every single step of that process. And I think that's a huge misconception. So knowing that not all of the embryos that come together are going to continue to grow, what does that mean for trying to freeze those embryos? When you freeze your embryos, why do you do that in the first place? Why don't you just transfer them right back in? When IVF initially was founded and they had the very first successful IVF pregnancy in the UK, that was a fresh transfer, meaning this woman had egg retrieval, not quite as intense as it can be now. She got a few eggs out. They took a sample of sperm, they put them together in the petri dish. This little human embryo was growing and the cells were dividing, and they put that right back into the body. So there was no cryopreservation at the time. And I do want to get into an episode about cryopreservation. It's fascinating. The way it came about is interesting. I'm not going to do that here. It's just too much information. But what are they saying statistically right now? At least in 2026 is where we're at. Most clinics say you want about 3 embryos to 1 live birth, because even if your embryos make it to day 5 and the cells were dividing normally, sometimes they'll go to day 7. When those embryos are frozen, if you decide to genetically test them, meaning before those embryos are frozen, they take a small sample of kind of the outer edge of that embryo. It typically turns into the placenta, and they send that off to a lab and say, hey, are there a normal number of chromosomes here? Why do they do that? Why do people have problems with this? And then let me just say, I totally get it. It sounds like very eugenicist and like, oh, you're throwing all these babies away. When IVF first started, the success rates were incredibly low. And when you are trying to bypass whatever fertility issues you're having, again, there's so many reasons why you might not be getting pregnant. And I tried to pull up some data where folks in the past have tried to quantify the number of embryos that are created without assisted conception, so natural pregnancy, and then the ones with assisted conception. Because when we think about, well, if you didn't get pregnant your very first month trying, what happened? Most of the time, we don't know. And how many embryos are typically lost in the process of trying to get pregnant naturally because of these reasons that we know now, where the cells weren't dividing normally, or something with the uterus, or whatever the case may be. And however many times it takes you to try to get pregnant, months or years, do we know those numbers? And can we compare them to assisted reproductive technologies? And quite frankly, I've read a few studies. I just did not think that they were worth pulling up, because you can't really quantify that right now. What they're saying statistically, at least as far as IVF goes, is that you want about 3 embryos to 1 live birth, because again, even if things are genetically tested and they're looking like they might not fail to implant or cause miscarriage, those things still happen just like they do in natural pregnancy, and they don't always know why and can't always prevent it. And in our instance, our first embryo transfer failed. And I went through something called a modified natural transfer. So you can do a fully medicated transfer, you can do some partial medications, or you can try and go based off of your own ovulation and have that embryo implanted back into your uterus and see if it will take. And sometimes they don't. And so for us, with that modified natural transfer, for a lot of reasons, I think my lining was too thin. I don't think I had enough progesterone. The natural ovulation thing, I have never responded very well to letrozole. It kind of messes with my body really bad. So it didn't work, and our embryo just failed to even implant. But even when you have genetically tested embryos, it's not a guarantee that that is going to prevent miscarriage and that you'll be able to see a live birth. The way that genetic testing was initially explained to me was that it will help reduce your chance of miscarriage. And what's interesting is that right now there are active lawsuits against the PGTA industry, not for the efficacy of their testing or what they're even doing. It's more so that the way that they're marketing this testing, aka it is 98% effective at reducing your miscarriage, is wrong. It is very effective at finding out, when they run their biopsies through their machine 50 times, it is 98% effective at saying, yes, this is exactly the number of chromosomes that there are, therefore, this is the likelihood of miscarriage. That's getting lost in translation, especially in America. And it's interesting because throughout the rest of the world, PGTA is not seen in the same light as it is in these clinics. And there are many, many people that opt out of it for religious reasons, for, ethical reasons, for financial reasons. And sometimes it's not even covered on insurance. It wasn't covered for us. So this is one that I think you really need to look into for yourself before you get to the clinic. Research it, think about it. I did this episode with a lawyer, Allison Freeman. She is one of the lawyers on these cases, and she is an IVF mother herself, and she is going after the PGTA industry. There was a lot she couldn't talk about, but we did discuss quite a few things I think it's worth listening to. I'm not saying that PGTA is ineffective, but would I personally do it again? I don't think so. And it's hard because I know many people who have chosen not to genetically test their embryos, and they are going through transfers now as they're trying to build their family out, and they're having failed transfers. And I don't think it's always clear what that exactly means to folks. And honestly, it's not super clear to me either, because my very first, quote unquote failed transfer didn't even implant. I think I knew why. I don't think I should have done that protocol that I did do, but I wanted to try it because I really wanted to try and avoid a fully medicated cycle. And imagine going through a fully medicated cycle. You are taking estrogen, which makes you sick and nauseous, and you have migraines for weeks just to build your endometrial lining. And then you add on intramuscular shots of progesterone. So you're being shot up with all these hormones. It's painful to take those shots, and it's a lot to manage. And sometimes you're adding other types of progesterone, and you're doing this for weeks and weeks. And then you transfer your embryo with best hopes, and then you have the most torturous 2-week wait. And it's actually a little less than 2 weeks because, again, when you remember kind of how we talked about those embryos, they're growing for 5 days typically. So minus, a couple of days off of that, you might take your HCG blood test about 9 days after your transfer. So it's not a full 2-week wait, but it's still pretty torturous. And then to have that not work, and you've gone through all of this money, all of this time, all of this pain and suffering, and all of the emotional hopes and fears and dreams that are wrapped up into this process, and it fails. So again, I know many people that this has happened to even recently, and it's a really, really tough process. And this is one of the many, many reasons why IVF is difficult and all of the steps you can take along the way. So that is a big consideration. I was trying to keep this episode short. I don't think it's going to be very short, but let's keep going. Fertility preservation, freezing your eggs or freezing your sperm. This is an incredible technology where you are cryo-freezing your gametes for future use. And it's not quite as good as freezing embryos, But for folks with cancer, for folks who haven't met the right person yet, who they want to build a family with, or other personal or medical reasons, it's a great option for a lot of people. And I'm just going to very briefly touch on this one, third-party reproduction. This is an arrangement where a person or a couple is receiving help from other people to have a child. So there's donor eggs, donor sperm, donor embryos, and surrogacy. Now I want to get into alternative methods. And I want to be careful about how I say this because, again, this is the Born of Science podcast, and there are studies. I mean, let me say it this way. There are a lot of people who can make a lot of studies sound the way that they want them to sound, and it's really hard as your average person trying to navigate this world and try to understand what's true and what's not true. I mean, not just in the fertility scope, but like in our world today, it is really hard to figure out what the truth is. And so when it comes to alternative methods, when you are in this position of extreme vulnerability where you want to build a family, it's a very natural thing. But when it comes to these alternative methods, there are some bad actors in these spaces. There are people who believe what they're doing is good and right and wonderful, but it is not effective. There are people that can take advantage. And so how do you navigate that? How do you find what's truthful and what isn't? When you go to a fertility clinic, there's a lot of treatments that they can do for you, like I've already discussed here. There are some clinics that will try and push people towards IVF before they need to go there. That is why, especially today, it's not uncommon to see people looking for alternative methods. And who can blame them? Nobody wants to pay $20,000 to $30,000 for one shot at bypassing whatever fertility issues you have, getting shot up with all these hormones. Nobody wants to do that. And if they do want to do that, I don't think they know what they're getting into. And so when you are trying to work with your doctor who knows a lot of things, let me give you an example. As someone who is trying to manage PCOS, I have known about this diagnosis now for 6, almost 7 years, and it is very hormonally complex. And every single person I've talked to, super qualified, mid-qualified, probably unqualified, have all had drastically different opinions on how to manage this condition. I have my own thoughts on that. We'll talk about that specifically in maybe a PCOS episode, but I had success anecdotally with a naturopathic fertility doctor. And so what is PCOS? It means you're not ovulating regularly. Why are you not ovulating regularly? Lots of different reasons. Typically, a very common one is insulin resistance. And the way that you can manage that is through diet and lifestyle that keeps your insulin regulated and more in control. That's the basics. There are several different phenotypes for PCOS. Sometimes insulin resistance is not as big of a factor as adrenal fatigue. And I don't want to get too complicated here, but the point is when I've tried to get this managed, even to this day, not just to get pregnant, but to maintain my health and to not develop cancer because I'm not regularly shedding my endometrial lining. All of those kinds of things I'm taking into consideration here. And these doctors, while they are well-meaning, all seem to have very different ideas about how to manage this, and none of them have worked for me so far. So what does that mean it hasn't worked? That means, have they been able to get me regularly ovulating, cycling, having menstruation under 35 days on a consistent basis? The answer is no. I am already doing that on an abnormal basis. So maybe 3 or 4 months out of the year, I'm ovulating, and I know because I'm tracking that, and my ovulatory window is between 23 and 35 days. And when it came to meeting with a naturopathic doctor, I kind of mentioned earlier, we went through this whole protocol. She kind of we did a very extensive blood panel to try to figure out what's going on in our body. And she knew I had PCOS, did one for my husband. We both did the full environmental panel as well, did all of this stuff to try and regulate. And for the first time, and I was tracking this with Mira, Mira is an at-home hormonal testing kit. They test, or at least when I was doing it, they could only test estrogen, progesterone, and I believe LH. And they have so many more options now. It's come a long way. There's other brands as well. I believe Anito is one of them. There's so many in this space. It's wonderful. I was ovulating 3 times in a row right after her protocol. Since then, I have not been able to get it that regular. I am more regular than I have been in the past, but it's not every single month. And I notice my symptoms much more postpartum than I ever did before. I don't know if that has to do with postpartum or if it's me being more aware of it or maybe a combination of both. So what I am trying to get at here is when it comes to alternative methods, again, lowest form of evidence, it worked for me and it worked for my husband because when he went through the protocol, we were looking for a new fertility clinic. We tried 2 different places and got a sperm analysis at both places because when he had his sperm analysis, and remember, he had low count, low motility, high DNA fragmentation at the first place. We went to this one clinic and they said his sperm was totally fine, came back normal, no issues. And we're like, well, that's kind of a fluke. We're going to try this other clinic anyway. Let's just test it again. Came back completely normal, totally fine. We're like, well, that's interesting. We tried a few more months naturally to conceive and it still wasn't working. At which point the opportunity came up to have a job with fertility coverage. And so knowing how rare that is and how rare it is to be able to work that kind of job into your life, we took the opportunity. Could it have worked? I don't think so. Maybe. You never know. And you can't let yourself get crazy over thinking about well, if I had known this and known what I know now in this circumstance in the past, would that change my experience? Like, you can't think like that. You can only think about, like, did I make the right decision with the knowledge that I had for myself and my family at that time? And so I don't have any regrets about going through IVF or anything, but I will say that for us, going to meet with a naturopathic doctor, trying to get to the root cause of our issues was helpful for us. And the naturopathic fertility doctor that we saw, Dr. Leah Gordon, shout out, her credentials. She graduated with honors from Colorado State with a degree in food science and human nutrition. So again, when we're talking about nutrition and how important that is, registered dietitians, wonderful people to reach out to, which she's not a registered dietitian. That was her undergrad. She went on to earn her naturopathic medical doctorate from, and I don't know how you say this, Bastyr, Bastyr University, one of the leading accredited institutions for the science-based natural medicine route. So I saw her information on a documentary about more natural living, and I get into that more in the second episode. We felt good about going to her because this was not someone who took an online course in a weekend and became a fertility coach or anything like that. And I'm not trying to bash those people. I'm trying to say when it comes to something as important as your fertility and people suggesting things like surgery, like when you go to someone in the NAPRO space who can do endo excision, which your fertility doctor likely can do. Maybe not the specific one you initially see, but there are some who specialize in endo excision. People will try to downplay and say that IVF is evil and it is bypassing and it's not solving any of your problems. And I'm pretty sure there's not a single person who believes that it solves your problems. It doesn't. But we would all like to solve our infertility problems. We would like to be healthy. We would like this stuff to not be having such a huge impact on our lives. And not just when it comes to things in the fertility realm, but folks with autoimmune diseases and all sorts of other stuff that we're being bombarded with. I feel like I'm saying that word a lot, but the point is, who would I avoid? I would avoid anyone without a credentialed degree. I would avoid anyone who is claiming that they have a cure for whatever type of infertility you are dealing with. I probably, and I am going to call out a few things here. I would probably avoid people who are trained in the Mercier method. I wouldn't avoid acupuncture, but I don't think it helps you get pregnant. If it makes you feel good and it helps you de-stress, wonderful, do that. If it's expensive and it's something you feel like you can't add into your budget, don't worry about it. I mentioned fertility coaches. people who say that you have to get on this specific fertility diet. You do need to be eating healthy. You do need to be removing junk from your life. But is that going to solve all of your problems? Maybe, maybe not. All right, we've been talking for a minute, but the very last section here that I want to talk about is kind of this hurry up and wait, and then all of the sources that I think you guys could look at that would be a great place to start. When we say hurry up and wait, like IVF, any fertility treatment itself generally does not take years to go through. That's not what is happening here. And I'll give you a solid example of me returning for further fertility treatment because we had frozen embryos that we would like to use to continue to build our family. So I am returning for treatment, meaning I am going back to do a frozen embryo transfer protocol, FET, very common. So I ended up calling the clinic in November of 2025, and they would not accept any new patients because when I would have been going through treatment would have been right through the middle of the holidays, and the doctors usually take time off during that time, like most of us do. So I got into the clinic January 2nd. I had to wait for my period to come, so I pushed it out a few more weeks. And once that period came, I had a new cycle where I was establishing a baseline. What does that mean? That means that IVF is a lot to go through in the first place. It's very expensive. Just because you have frozen embryos doesn't mean that they're going to transfer them for free. It's thousands of dollars every time. So when they're establishing a baseline, they want to make sure that there are not any other issues that have come up since the last time you were in for treatment and this time, so that they're not wasting your time and money. So they're looking at the state of your uterus. I did a water ultrasound. Remember the saline sonogram, SIS? We talked about that earlier. Maybe they're looking at your ovaries, maybe with a pelvic ultrasound, depending on what you've got and why you're there. They could be going over any relevant blood work. I did a CBC and a few other things for PCOS, and they looked at like my vitamin D levels, simple things like that, because vitamin D is a big deal. Then they wait for a period again. So that was your baseline cycle because they have to do it on certain days of the month, or induce a period. So I induced my period with a medication called Provera. Or medroxyprogesterone is a generic. You guys will probably be familiar with that if you ever end up going through treatment. And that was Thursday, the 29th of January. So this is kind of the timeline here. That's what I'm walking through. A new transfer protocol, meaning my frozen embryo transfer, that FET protocol, my calendar, my plan of care, many words for it, that officially came and was delivered to me and ready to go. And I had my date set for February 6th. Where I began oral medication for a fully medicated cycle. Then I was on 21 days of estrogen before my transfer protocol, at which point I was transferring a 5-day embryo. And remember, if ovulation is roughly happening around that 14-day window, depending on your cycle, you've had an embryo that has grown for 5 days. And so in natural ovulation, that pushes you out a few days. So that's why you're on meds a little bit longer than that 14 days. So 21 days of meds before my transfer protocol, then a few days of rest, and a little under a 2-week wait. So end to end, it was 44 total days between the time I took my first meds to induce a period, and then I am now a few days away from my blood pregnancy test. So when it comes to this hurry up and wait, it's like, hurry, call your clinic, get an appointment, then you might have to wait a few months. And especially like I know my clinic right now is doing a lot of, there's a lot of research coming out about growing eggs outside of the uterus to try and avoid really intense things like OHSS, which I had, ovarian hyperstimulation syndrome. Can they do that? Can they protect those eggs? There's a lot of studies going on with things like that right now. There are studies where you're doing very, very low stim IVF, mini IVF, if you will, where you're not trying to grow a bunch of eggs at once, you're just growing a few. And especially if this is like a religious concern for you, there's so many things. Like I want to make it clear for you guys that if you have religious concerns with IVF, your doctor is going to work with you. And if they don't want to work with you, find another one. There's plenty of them out there. And I don't think that should inhibit you from trying to build your family. And I do get into it in another episode as well, but as complicated and wonderful and beautiful as adoption and fostering can be, There are many more people out there who want to build their family than there are children who can be helped in these instances. And so when people say things like just adopt, like they don't know what they're talking about. And first of all, like we need to stop listening to other people who have never lived the life experience that you're about to go through and maybe don't have the same beliefs that you do. And I think it's good to talk to each other and understand our different perspectives. But stop taking advice from those people because half the time they don't even know what they're talking about and can't even explain IVF. So those are my 2 cents. I'm done with that. Let me tell you some sources here. Where can you go? Where can you find truth and knowledge and wisdom? Some of the official institutions, I've already mentioned this. ASRM is the American Society of Reproductive Medicine. Sometimes you can browse through the Journal of Fertility and Sterility, which I do just for funsies. SART, the Society for Assisted Reproductive Technology, and there are many, many practicing reproductive endocrinologists that are on social media and or have podcasts and or have books. So I listed out a few of my favorites here that I would recommend you guys look at for yourself. Okay, so some of my favorites, Dr. Lucky Seacon. She's going crazy right now on social media because she just released her book, which I have here. Let me pull it up. Okay, here we go. The Lucky Egg by Dr. Lucky Seacon. And this is not just a book about fertility. It's about all things fertility and health because your fertility is a marker of your health. So it's awesome. It's got a great, I'm going through it the second time now. There's just so much information there. And then she's on social media. You can see her posting information all the time. Dr. Stephen Palter, he is East Coast. Well, his clinic is called Gold Coast Medicine, East Coast Medicine, something like that. Anyway, he's on social media. He posts a lot of really great information. Dr. Natalie Crawford, another one of my favorites. She has a podcast as a woman, and I believe her book is coming out soon too. And then Dr. Sasha Hockman. She has a podcast, Trying to Conceive Pod, and she's also on social media. Dr. Amy, I know she doesn't post her name. I should have looked this up beforehand. Evazadeh. Sorry if I said that wrong, Dr. Amy, but she's the Egg Whisperer, and that podcast has been around for a long time. She's got great information, and she pulls in other professionals with her as well. And then another great book, podcast/book resource, The IVF Blueprint, another wonderful one. This is by doctors Abby A. Lynn, Carrie Bendient, and Susan Hudson. They're from the podcast Fertility Docs Uncensored. These are great resources. And you guys, like if you're listening to these resources and sometimes they get pretty clinical, like the SART Society of Assisted Reproductive Technologies, they also have a podcast and they are typically doctors speaking with one another. Sometimes it can get really clinical. I enjoy listening to that. Not everybody does. Amongst all of these resources, hopefully you can find someone who you really enjoy listening to, but I would listen to doctors. There are people like me doing podcasts. I'm not credentialed. I'm not a doctor. I'm not even a nurse. Anyone who's worked in this field, nothing. I'm not an embryologist. I am just a patient, but I'm a patient who's gone through this and was pretty frustrated by the communication process, which is why I'm doing a podcast now. And I built an app called Coconut Cycles to help digitize and better manage your treatment protocols and communication between the clinic and you. It is a lot. It is so much to manage. And without going into too much detail there, I have a couple more resources I wanted to show to you. Registered dietitian Corey Ruth. She is the women's dietitian. She also has a book called PCOS is My Power. She's wonderful. I have learned a lot from her. Another great follow that I love, Hannah. She is the conscious nutritionist, also a registered dietitian and PA. She talks about PCOS. Sorry if these are, only PCOS specific. I have looked up a lot of endometriosis because I know that's another common one. Look them up for yourself. Find people that you like. I've added and removed people over the years based upon understanding more about what their credentials are and how they present information. So go do that for yourself. There's also Dr. Allison Gottschalk, if that's how you say her name. She is a naturopathic doctor out of Canada, also talks about PCOS, and she has an excellent way of explaining these very complex hormonal things that are happening in our bodies and all of our different phenotypes, and it makes it so simple for you to understand. She's another wonderful resource. A book that I was recommended by my naturopathic doctor. I was recommended this book. 8 Steps to Reverse Your PCOS. And it is by Fiona McCullough. She's a naturopathic doctor, and it was published in about 2016. 2016 was 10 years ago, for the record. And I liked it. I think if you know absolutely nothing about what PCOS is, it's a pretty okay place to start, but I would probably start with the newest information that you can find. Like I mentioned earlier, PCOS is my power. Also, none of this is sponsored or anything. These are great resources, and it's hard to, again, know like what is a good resource and what isn't a good resource. When it comes to things like It Starts with the Egg, and there's a few different books like this one out there. I've asked many a doctor about this, and Rebecca Fett is the author. She has a degree in molecular biology and biochemistry, so super smart. She knows a lot about genetics, and yet she's talking about the science of egg quality and, all the foods that you eat. And I'm not saying the information's bad, but when it comes to what is the most relevant and up-to-date information, this probably doesn't hit the mark there. I wouldn't waste your time with it. It was never even recommended to me. A friend gave me that book, and I read through it because I just wanted to know what about this used to have such a hold on people, because I think many people used to swear by that book. And a lot of this information is already out here, but it has more updated information. And I think, for example, with things like the fertility diet, again, with some of the latest studies, you don't have to freak out if you are not on the fertility diet, because I think it's common that we can find ourselves in this place of, if I don't do everything exactly right, does that mean I'll never get pregnant? I know this person who is able to reverse their PCOS and they're totally healthy. Am I being lazy? Am I not implementing this right? Should I be cutting out certain foods? Am I you can drive yourself crazy with that stuff. And at the end of the day, the truth of it all is that infertility is super unfair. And there are plenty of unhealthy people, plenty of super stressed out people in war zones who are conceiving, and you're not. And so if you do all of these things, is that really supposed to change things? And that is quite the debate. What you need to just be most worried about is just trying to be healthy and trying to find the right sources from the right people. So I think we're going to wrap it up here. Thank you, everyone, for listening. This is Born of Science podcast. I have a whole season coming out. I've got 10 pre-recorded episodes and a few interviews. I'm excited to go through them with you guys. Again, the reason I'm doing this, I want to build community. I want people to know what the truth is and not be taken advantage of by people who are selling you supplements that are going to solve all of your problems. And I think that we just need to be coming into fertility treatment with much more informed consent than is currently happening. So if you need help with your fertility treatment, check out my app, Coconut Cycles. I have it available in the App Store. I'm so excited, and I would love your feedback. And I want this to be a resource for you to try and reduce that mental load that is fertility treatment. So if this was helpful for you, please like, rate, and review. I love to hear from you. Send me a DM, and we'll see you next time. Fertility medicine is a rigorously trained, evidence-based field, but biology doesn't always behave predictably, even when care is excellent and protocols are followed. If this episode raised any questions for you, consider writing them down, whether that's for a future appointment or in the Coconut Cycles app to bring into conversations with your care team. This podcast is for educational and informational purposes only. It's not medical advice, and it doesn't replace conversations with your own doctor or care team. Any views expressed by our guests are their own and don't necessarily reflect mine or Born of Science. If this episode was helpful, give us a rating, follow the show, and share it with someone who needs it. And we'll see you next time.